Is to discuss the identification of the women at increased risk of maternal collapse, to identify the different causes of the maternal collapse, to delineate the initial and the continuing management of the maternal collapse, and to review the maternal and the fetal outcomes. Now, what do you mean by the maternal collapse? An acute event involving the cardiorespiratory system and or the brain, resulting in the reduced or the absent conscious level and potentially the death of the female at any stage in the pregnancy and up to 6 weeks after the delivery. This is very, very important. Up to 6 weeks after the delivery is included in the maternal collapse. Can a woman at risk of impending collapse be identified early? This is our duty. Either we can identify that lady during the pregnancy, we can identify the risk factors, who are the women who are at risk of developing the cardiac arrest at the time of the delivery or during the preperium. An obstetric early warning score chart should be used routinely for all the women to allow the early recognition of the woman who is becoming critically ill. It depends on the previous risk factors during the pregnancy. How you are going to identify the risk factor during the pregnancy? By taking the detailed history of the patient, the personal history and the family history of the patient. If there is any important risk factor present during the pregnancy, you people should be very, very careful while handling these patients during the pregnancy and the puerperium. Now, what are the causes of the maternal collapse? There are the number of causes. A systemic approach should be taken to identify the cause. Reversible causes include the 4H's and the 4T's. 4H's includes the hypovolemia, hypoxia, hypokalemia or hyperkalemia, and the hypothermia. 4T's include thromboembolism, toxicity, tension pneumothorax, and the tamponade cardiac. The reversible causes, then I have already discussed. 4X includes the hypovolemia, causing the pregnancy is because of the bleeding. Bleeding because of the obstetric reason, it can be concealed or it can be revealed. Concealed bleeding is in case of placental abruption, okay, and revealed bleeding is mostly in the cases of placenta previa, okay, or the relative hypovolemia of the dense spinal block, septic or the neurogenic block. Hypoxia, pregnant women can become hypoxic more quickly. Cardiac events, peripartum cardiomyopathy, myocardial infarction, aortic dissection, large vessels, aneurysms. I have seen lot of patients in my practical life dying immediately post-operatively because of the sudden cardiac arrest. And after the death of the patient, when we make the diagnosis, and the cause turned out to be the peripartum cardiomyopathy. Okay. So the prophylaxis we people are taking in these patients, in all our antenatal patients, we are going for the ECG of the patient in the first trimester, and if there is any suspicion, we are going for the echocardiography of these patients in the first trimester, not at the end of the pregnancy. Then is the hypo and the hyperkalemia. These are no more likely. Hyponatremia can be caused by the oxytocin use. What is the use of oxytocin? To contract the uterus. Overdose of the oxytocin can lead to the hyponatremia and the maternal collapse. Then is the hypothermia, no more likely because we people are giving the best cares to the patients nowadays. Now 4T's, thromboembolism, amniotic fluid embolus, pulmonary embolus, air embolus, and the myocardial infarct. Toxicity because of the local anesthetic agent, magnesium, and the other. Where we people are using the local anesthetic agent in obs-and-gynae, in obstetrics, in episiotomy. So whenever you give the local anesthesia to the patient for giving the episiotomy, pull the plunger outside whether you have not pricked the blood vessel. Agar needle within the blood vessel, you have to change the place. Okay, this is very, very important. Then is the magnesium. Magnesium is given for, magnesium sulfate is given for the prevention of the fits in the patients with eclampsia. Okay, जिन patients में with a high blood pressure there are fits. In order to control the fits, we have to give the magnesium sulfate. And then there is a proper dose of magnesium sulfate. If you give the magnesium sulfate unchecked without dilution, it will lead within 1 or 2 minutes to the cardiac arrest because it will cause the cardiac spasm. Okay, so this is very important. Tension pneumothorax, falling trauma, suicide attempts, tamponade, falling trauma, suicide attempts. Then is the eclampsia, and preeclampsia includes the intracranial hemorrhage, sudden increase in the blood pressure. All these causes lead to the maternal collapse. So you can see why this topic is very important. All the obstetric complications can lead to the maternal collapse, and you people should know how to resuscitate the collapsing mother. Because we are dealing with the two lives, mother and the baby, we have to save the mother as well as the baby. This is the diagrammatic approach of the causes of the maternal collapse. Starting from the brain, it's easy to memorize, you people. That is, in the brain includes the eclampsia. Eclampsia can lead to the intracranial hemorrhage. Okay, then comes to the mouth of the patient. Please be interactive. थोड़ा सा जागे. Drug overdosage of any drug toxicity can lead to that. Anaphylactic shock can result into that. Then is the drug you are giving in the intramuscular or IV injections, that is magnesium sulfate, local anesthetic drugs. Then is when you come down into the lungs, it can lead to the pulmonary embolism, amniotic fluid embolism. And when you go into the heart, it can lead to the aortic dissection. Cardiac causes include the arrhythmias, myocardial infarction, pericardial cardiomyopathy. Then goes into the tummy of the patient, that includes the hepatic rupture, that can be because of any trauma or hypoglycemia. And if there is any accident, pregnant lady can have the road traffic accidents. We are dealing with the road traffic accident patients over here in Hali Fatma. Lot of patients, because यहाँ पे हर दूसरे दिन कोई ना कोई accident हुआ होता है. ठीक है, तो we people should know splenic artery rupture. Uterine causes include the antepartum hemorrhage and the postpartum hemorrhage. And the sepsis, the most common cause of the maternal collapse. So you should investigate the sepsis of the patient as well, if she collapsed immediately during the pregnancy or the postpartum period. Okay. Now, what are the physiological and the anatomical changes in the pregnancy that affect the resuscitation? Why the maternal resuscitation is different from the resuscitation of the non-pregnant patient or the other individuals? Anyone involved in the resuscitation of the pregnant women is aware of the physiological differences. Okay? You people should know what are the physiological differences between the pregnant lady and the non-pregnant lady. Okay? First of all is the cardiovascular system. Who will read? Last one with the cap. जब आप in the wards, you people are dealing with the pregnancy increased by 10% at term. Systemic vascular resistance is decreased. Arterial blood pressure is decreased by 10 to 15 millimeter of mercury, and the venous return decreased by the pressure of the gravid uterus on the inferior vena cava. Now, how these changes are affecting the resuscitation of the patient? Whenever the plasma volume increases, there is a dilutionary anemia. Okay? And reduce oxygen carrying capacity of the patient. Whenever the heart rate is increased, increase CPR circulation demands. You have to increase the CPR of the patient. And whenever the uterine blood flow is increased, then potential for rapid massive hemorrhage is increased, either because of the placenta previa or because of the placental abruption or the postpartum hemorrhage. Then is the systemic vascular resistance, that is also the blood during the CPR. It will sequester, it will decrease during the CPR. So you have to put more efforts in the resuscitation of the pregnant lady. Arterial blood pressure is decreased by 10 to 15 millimeter of mercury and decreased reserve. Venous return is decreased, so increase the CPR circulation demand and decrease the reserves. Now, what happens to the respiratory system? Respiratory system includes oxygen consumption and the carbon dioxide. Okay, so oxygen consumption is increased by 20% during the pregnancy and decrease the during the resuscitation. It decreases the buffering capacity and acidosis more likely. Physiology you people know much better than us at this stage, because you people are freshly reading all these things. Okay, residual capacity is decreased by 25%. Hypoxia develops more quickly when apnea develops in these patients. Arterial partial pressure of carbon dioxide is decreased and it decreased the buffering capacity. These things are very important to know from the resuscitation and from the MCQ's point of view. So you people should memorize this. Laryngeal edema is increased and difficult intubation. हर जगह swelling हो जाती है, larynx की भी swelling हो जाती है. When you pass the ETT in these patients, तो little bit smaller size आपको choose करना पड़ता है, but sometimes it would be difficult for you to pass the ETT. Anyone who has passed the ETT till now? नहीं. Anesthesia में rotations हो रही है आपकी? Okay. Increase risk of aspiration. आपने सुना होगा हर each and every pregnant patient she used to say कि डॉक्टर साहब मुझे constipation हो गया. What is the reason of constipation? Increase in the level of the progesterone, and it affects the resuscitation of the patient because the gastric emptying is delayed, so it increases the risk of aspiration. Okay, low esophageal sphincter is relaxed and increase the risk of aspiration. Uterus is enlarged, diaphragmatic splinting reduces the residual capacity and makes the ventilation more difficult. Aortocerebral compression causes the spine hypotension, reduces the venous return and significantly impairs the CPR. Weight is increases, large breast may interfere with the intubations, make ventilations more difficult. Aortocerebral compression significantly reduces the cardiac output from 20 weeks onward. Before 20 weeks, the baby is not pushing, giving the pressure on the inferior vena cava. After 20 weeks of gestation, 20 weeks is the landmark of the 20 weeks is umbilicus, okay, above the level of the umbilicus. Below is 18 weeks, above is 20 weeks. After 20 weeks of gestation, the resuscitation is difficult because aortocerebral compression is increased. Aorta and inferior vena cava both are compressed, and efficacy of chest compression during the resuscitation. Changes in the lung function, diaphragmatic splinting and increased oxygen consumption make the pregnant women become hypoxic more readily and make ventilation more difficult. Difficult intubation is more likely in the pregnancy, and the pregnant women are at increased risk of aspiration. Now the mother is collapsed and you are standing over there, either in the ward, either in the road or in the market. The pregnant lady collapsed. Now what is the initial management you people have to do? Maternal collapse resuscitation should follow the standard A, B, C, D, E approach, okay, as like that of the other resuscitations, with some modifications for the maternal physiology, in particular relief of the aortocerebral compression. In maternal cardiac arrest occurs in the community setting, basic life support should be administered and rapid transfer should be arranged. Okay. Manual displacement of the uterus to the left. Okay. Effective in यानी आपने uterus को उठा के बेबी को left side पे push कर देना है. Okay. Effective in relieving the aortocerebral compression in the women more than 20 weeks of gestation or where the uterus is palpable at or above the level of the umbilicus. This permits the effective chest compression in the spine position in the event of the cardiac arrest. Okay. This state will remove the aortocerebral compression and it will also help you in the chest compressions of the patient. A left lateral tilt of the women from head to toe at an angle of 15 to 30 degrees on a firm surface will relieve the aortocerebral compression and still allow the effective chest compression to be performed in the event of the cardiac arrest. In the community setting, अगर आपको left lateral tilt hand से करना नहीं आ रहा, how to push the pregnant uterus on the side? Remember this position. Place the patient on some hard bowl or some hard bed or something like that, and place anything, pillows or bed sheets or anything like that on the right side of the patient so that the left tilt of the patient should be appreciated in order to avoid the compression of the inferior vena cava and the aorta. Now, management consists of A. A is for the airway, okay, with a cervical spine control. First of all, you must have to clear the airway. कि उसके माउथ में तो कोई ऐसी चीज नहीं है जो उसका एयरवे ऑब्स्ट्रक्ट कर रही है. Open the person's airway using the head, tail, chin and the left maneuver. You can easily appreciate in this diagram head, tail, chin, left maneuver. Okay. Then you have to check for the breathing. B is for the breathing with ventilation. Look for the chest movements. Listen for the breath sounds and feel for the movement of air for a maximum of 10 seconds. If the breathing is present, give high flow oxygen. If the breathing is absent, start the ventilation. We will revise at the end from your side. Excuse me, last one.